Good afternoon, students. Today we will be continuing our series in the central nervous system examination. Today we will be focusing on coordination. We will begin as always by maintaining rapport with the patient and introducing ourselves. So good morning.
Good morning, teacher.
My name is Dr. Gale. Is it okay if I examine you?
Yeah.
Okay, perfect. Then you give the patient the instructions and we will be beginning with the evaluation for dysmetria. So Marcel, I want you to touch my fingertip with your finger and touch the tip of your nose. And I want you to do that quickly and accurately. Repeat, keep going. Do it as fast as you can. And the key points to note, students, the patient has to extend their elbow completely. And usually with preserved cerebellar function, the patient is accurately able to touch the tip of the finger. In patients with cerebellar disease, what usually happens is that they have what's called an intention tremor. So when patients have a cerebellar intention tremor, as they approach the target, the amplitude of the oscillations of their tremor increases the closer they get to the target. And oftentimes, the target is overshot, and that is a hallmark of an intention tremor, as well as dysmetria. So let's demonstrate normal. Touch your nose and touch my fingertip, extending the elbow, and do it as quickly as you can. Perfect. And we check the alternate hand. Touch the tip of my finger and your nose. So you stay as far as possible to allow for extension of the elbow. Perfect. All right. The next maneuver will be testing for dysdiadochokinesia. And we ask the patient, extend your left palm. Extend your left palm. And you are to tap on the back and the front of your hand alternately. And it should be done quickly and accurately. So that's testing for rapidly alternating movements. And this is the evaluation for dysdiadochokinesia. In patients who have cerebellar lesions, this is often done erratically and with alternating rate and alternating rhythm. In a normal, healthy subject, this is done rapidly and efficiently. All right, other hand. Oftentimes, you will note that if a patient is right-handed, that they're able to do it just a little bit better with their right hand as opposed to with their left. And Marcel is demonstrating it clearly here, that it's just a little bit slower on his non-dominant hand. But still, the rate and the rhythm and the accuracy is normal. All right, perfect. Okay, can have live for me, please? So now we will be demonstrating the heel-shin test. And for this, we're going to roll the pants up to expose the knees. And the patient is asked to lift one leg, placing their heel on the other knee, and slowly but accurately dragging the heel all the way down to the ankle. At this point, the foot is lifted and the heel is put on the knee, and the action is repeated. Can you lift, place, Do it quickly but accurately. For patients with cerebellar dysfunction, or oftentimes with profound sensory abnormalities in their lower extremities, such as proprioception and light touch, they often have difficulty completing this task. We're going to alternate the knee all the way down, lifting the heel and placing it on the knee. And this is done accurately in a straight line. For patients, again, who have cerebellar disease, oftentimes you will note that the heel staggers on either side of the anterior aspect of the shin. Or for patients who have abnormalities with their sensory systems, for example, joint position sense, they have difficulty completing this task accurately. So once again, the normal heel shin on the knee, sliding down in a straight line to the ankle, lifting up the heel and placing it accurately on the knee. Thank you, Marcel. So good afternoon, students. Welcome again to the CNS series. Today we will be focusing on the motor examination. Before you begin, you will need your patella hammer. You will also need to adequately expose the patient, exposing his thighs, and he should be placed in what's called the anatomical position, lying supine with the hands, with the palms facing up. Again, we maintain rapport with the patient at all times by introducing ourselves and asking permission to examine him. Good afternoon. I'm Dr. Gale. Is it okay if I examine you?
Okay.
If you're in any discomfort, just let me know.
Okay.
Okay? All right. And we usually examine from the foot of the bed. And so we will assume that position now. So from the foot of the bed, we quickly inspect the patient, and we're looking generally for features related to the patient's nutrition, the age of the patient. We're looking at his bedside to see if there are any appendages, so to speak. For example, an IV line, oxygen therapy, a urinary catheter, a wheelchair. Is the patient wearing Pampers or not? Then, more specifically, we're looking for the bulk of his muscles. And of note, in this patient, we have some wasting of the biceps, triceps, as well as the deltoids. And that is seen bilaterally. We're also looking for the attitude of his limbs. In some patients, we may note bilateral foot drops, where the foot is plantar flexed. We may also see evidence of external rotation of the limb. And in others, we may see what is called scissoring of the leg, where the legs are almost crossed, or at times there is adduction of the knees. With bilateral foot drop, may have a peripheral neuropathy. In other cases where scissoring is seen, that may be suggestive of an upper motor neuron process. We also look for signs of visible abnormalities, for example, neurocutaneous lesions like cafe or lay spots, as well as neurofibromas, which may be seen in neurofibromatosis. From the foot of the bed, we may also see spontaneous fasciculations. Now, fasciculations are contractions of small motor units or motor fibers, and these do not usually result in gross movement of the muscles. This may be seen in any distribution. It may be unilateral in an isolated muscle group, or it may be seen multifocally. And this points to lower motor neuron disease pathology. At this time, it's important to note that the lower motor neuron actually begins anatomically in the anterior horn cells and continues distally through the radicals, through the plexus, and out into the individual peripheral nerves. And so any disease process that affects any of those segments of the lower motor neuron can result in a unique set of clinical findings, one of which includes fasciculations, and another, which was alluded to earlier, includes a loss of muscle bulk. For completion, the upper motor neuron extends throughout the corticospinal tract and involves any level from the cortex, subcortex, through the internal capsule, through the midbrain, all the way down into the spinal cord until the anterior horn cells are reached. So the corticospinal tract exemplifies the upper motor neuron just proximal to the anterior horn cells. Of course, likewise, the corticobulbar tract from the cortex all the way into the brainstem, just proximal to the cranial nerve nuclei, all of that represents the upper motor neuron. And so as it relates to the corticobulbar system, the lower motor neuron begins at the cranial nerve nuclei and extends distally into the cranial nerve fascicle and then into the cranial nerves themselves. At this point, we can ask the patient to activate their muscles by asking them, "Sir, can you raise your left hand, please?" Okay, can you put it on the bed? Perfect. Can you raise your right hand, please? Can you put it on the bed for me? Good. Can you raise your left foot? Good. All right, can you put it on the bed? At this point, we will know that the patient has at least grade 3 power in all of the requested limbs. And I know that later on in the talk, we will have to discuss the grading system of motor power. At this point, if the patient is unable to lift their limb, they are then requested to move the limb in the plane of gravity. So, "Sir, can you lift your right leg for me?" If they're unable to do that, the patient is asked, "Can you move your right leg towards the edge of this bed?" And we know that the patient is able to move the limb laterally without the influence of gravity, and that gives the patient a grade 2 in that leg, at least a grade 2 in that leg. And as I said, we will discuss the grading system for power shortly. We then move to the side of the bed where we ask the patient, "Are you feeling any pain?" No. And we will begin by evaluating the bulk of each of the muscle groups. Using both hands, we gently palpate the biceps alternately, confirming the loss of bulk. Then we move to the forearm on the same limb, and then across to the contralateral side. And then we examine the bulk of the thighs alternately, and then down into the calf of the same leg, and then across to the contralateral side. And we now document that the patient has decreased bulk in both his proximal muscle groups, biceps, deltoid, and triceps, as well as his distal forearm muscles. and with preserved bulk in the thighs as well as the calves. We then move to evaluation of tone, and we will begin with the right arm. For the shoulder joint is capable of 360-degree movement, and so the joints are moved in the range of motion of the joint. So 360 degrees. And we're looking for a measure of the resting tone in the joint. It can be normal, it can be decreased in lower motor neuron processes, or it can be increased in upper motor neuron processes. For the elbow, the patient is subjected to flexion, extension movements. We then go to the contralateral side, flexion and extension. Now at the elbow joint, we're able to evaluate for various patterns with regards to the tone. For example, if the tone is reduced or hypotonic, the patient's arm feels quite floppy. Marcel? And this feeling of floppiness is something that you will have to acquire throughout the course of the clerkship. The rate at which the arm is flexed or extended, however, should be at a moderate pace at approximately this speed. There are other patterns that can be seen, especially with upper motor neuron processes, where spasticity or rigidity may be detected. Classically, for spasticity, especially clasp knife spasticity, which is a hallmark of corticospinal tract involvement, there is resistance to the movement of the joint, but usually at the onset with a sudden release and relative freeness of movement thereafter. So there is resistance at the onset, and then the joint moves freely. And that is a hallmark of clasp knife rigidity. Let's demonstrate. There is resistance at the onset and then a give, and the joint moves freely. As it relates to rigidity, rigidity classically is seen in involvement of the extrapyramidal system, and the hallmark is lead pipe rigidity. And what that is that there is resistance to movement of the joint throughout each range of movement. Now, oftentimes patients with lead pipe rigidity or extrapyramidal disease, for example, Parkinson's disease, they have an associated tremor. And that tremor, when combined with lead pipe rigidity, gives what is called cogwheel rigidity, where the patient exhibits alternating give, resistance, give, resistance, give, resistance throughout the course of movement of the joint. Having completed those in the upper limbs, we then go to the ipsilateral lower extremity. And as it relates to the hip, we can do 360 degrees of movement. And so the hip is moved throughout 360 degrees. At the ipsilateral knee, flexion and extension. Bend your knee. Let me bend your knee. Flexion and extension. We then go to the contralateral knee, flexion and extension. And we're noting whether the tone is normal, reduced, or increased. At the ankle, again, flexion and extension. Okay. Now, from the foot of the bed, we had observed 4 spontaneous fasciculations. If those are not seen, and especially if we are suspicious of a lower motor neuron process, we may elicit fasciculations by tapping gently on the muscles and observing for the contractions of the individual motor units. Okay, perfect. At this time, we will move to the examination of power. The evaluation of power includes a knowledge of the Medical Research Council criteria for power. And that includes a grading system from grade 0 to grade 5. 0 power is absolutely no engagement of the muscle. Grade 1, the patient is able to do just a flicker of movement. So Marcel, can you just contract your muscles, your biceps? So just a flicker of movement you can see, but it does not move the muscles around the joint. Then for grade 2, the patient is able to move the limb when gravity is eliminated. And usually that is in the horizontal plane. So Marcel, can you move your hand towards my hand? Perfect. That is grade 2 power. Again, when gravity is eliminated within the horizontal plane, the patient is able to move the joint subserved by the muscles being tested. For grade 3 power, the patient is able to lift the limb against gravity, but not against resistance. So Marcel, can you raise your hand for me? So the patient is able to lift against gravity, but not against my resistance. For grade 4 power, bend your elbow. Can you keep your elbow up? For grade 4 power, the patient is able to lift against gravity as well as against my resistance, but it is not normal power. I am able to overcome them as demonstrated here. Keep your elbow up. Don't let me push it down. As you can see, I am able to overcome the movement around that joint, which is abduction. Let's demonstrate again. So in asking the patient to abduct the arm with the elbow flexed, I say, sir, keep your arm out. I am able to overcome with my resistance, and that is called grade 4 power. Grade 5 power is when the patient has normal power. Keep your arm abducted. Keep it out. Don't let me overcome. With resistance, I am not able to overcome the patient's action. And that is normal power. Okay, so now we're going to demonstrate the posture for the proper evaluation of power in all the muscle groups. A subtle way to evaluate for mild loss of power is asking the patient to do what is called a pronator drift. Patient is asked to extend the arms, palms up to the sky, usually about shoulder width apart. They are then instructed to close their eyes and to maintain their limbs at this posture and this level. Please note that the arms are under the influence of gravity, and a patient with normal power should be able to maintain their hand at this level. If they have mild reduction in power, a few things may be seen. Number 1, mild pronation of the arm. Or you may see mild drifting of the arm where one arm is lowered below the other. Or you may see both, where there is pronation and a drift. Depending on the severity of power loss, the patient may have a profound drift where the arm slumps down to the bed quite quickly. So Marcel, let's pretend that you have weakness on this side. Close your eyes, keep the arms at this level. And this arm that's weak will fall to the bed. Marcel, let's pretend. With the healthy arm with intact power, maintaining the posture. Okay, we're gonna now start with shoulder abduction, abduction. So the patient is positioned with the arms abducted and the elbow flexed. They are asked to maintain this posture against resistance, and the examiner applies pressure to the upper surface of the elbow. Marcel, keep your hands, your elbows up. Don't let me push them down. Keep them up, and a patient with normal power will be able to maintain this posture against my resistance. Of note, shoulder abduction is performed by the deltoids, and that is C4, C5 dermatome. Push down on my hand, shoulder adduction, push down on my hand, push down. Perfect. That again is normal power. The patient is able to maintain the directive given without being overcome with my resistance. Then we test the arms alternately. Elbow flexion with our hand on the distal aspect of the forearm and the other hand on the bicep muscle. Marcel, can you pull me towards you? Pull. Note the flexion of the biceps. Pull. And I'm unable to overcome the patient. Again, grade 5 power. At this level, C5, C6, myotome. The alternate bicep, again, the hand is positioned in a fist, palms facing the face. The hand that's applying the resistance to the distal aspect of the wrist, and the other hand over. Can you pull me towards you? Pull, pull. Again, I am unable to overcome the patient. Staying with this hand, we're now going to do elbow extension, which involves the patient pushing me away. Of course, we have our hands on the triceps, and the patient is given the instructions. Can you push? Push me away. Push, 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 push. Again, I am unable to overcome the movement. C7, 8 is the myotome. Alternate hand, positioned again with the palm facing the face. Triceps are palpated. Can you push me away? Push, 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 push. Good. Unable to overcome, that's grade 5 power. For wrist extension and flexion, the patient is asked to make a fist, and we usually do isometric holds. For example, we say, sir, can you maintain your fist in this position? And with our fisted hand, the patient is asked to resist. Sir, push against my hand, and this action tests wrist extension. Make a fist. Again, with the fisted hand, pushing against, sir, push against my hand, push, 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 push. And this tests wrist extension. Sir, can you push down on my fist? evaluating wrist flexion. Make a fist. Evaluating wrist flexion. Can you push down on my? Perfect. All right, that's wrist flexion. Now, as it relates to the small muscles of the hand, these are subserved predominantly by the C8T1 dermatome, the thenar and hypothenar eminences. We can observe for atrophy of the thenar eminence, or on the dorsum of the hand, if the patient has wasting of the small muscles, we will see prominence of the extensor tendons with guttering between the tendons. Again, looking at the small muscles of the hand, we can test these individually. For example, abductor pollicis brevis. We ask the patient to keep the palm flat, abduct their thumb. Sir, can you point your thumb towards your face? And we apply pressure to the metacarpophalangeal joint. The patient is able to maintain that posture against my resistance. And that is a median nerve, C8 predominantly myotome. So we test flexion at the metacarpophalangeal joint, an action that's subserved by flexor digitorum superficialis. You ask the patient, sir, make a fist. And while the patient makes a fist, you try to extend the metacarpophalangeal joint. And if the patient has normal power, then you are unable to do that. Likewise, flexion of the distal interphalangeal joint is done by flexor digitorum profundus, the lateral 2 being subserved by the median nerve, the medial 2 by the ulnar nerve. Sir, keep your fingertips bent. Don't let me straighten them. Perfect. Keep your fingertips bent. Very good. Likewise, the dorsal and palmar interossei muscles, which subserve adduction for the palmar and abduction for the dorsal, can be grossly tested by asking the patient to maintain a sheet of paper between two fingers while the examiner gently tries to remove the paper. Sir, keep your fingers together. Don't let me remove the paper. Perfect. Keep your fingers together. Don't let me remove. Perfect. Excellent. And this series of tests is repeated on the contralateral hand. In the lower extremity, the first movement is hip flexion. Can you bend your knee for me? Bend your knee. So the knee is bent at 90 and the hip is bent at 90, and the patient is instructed, sir, can you bring your knee towards your face? And your hand is placed just proximal to the patient's knee. Bring your knee in towards your face. Go. With normal power, again, the patient maintains that posture. And this action is subserved by L1, 2, and 3. Can you bend 90 degrees at the knee? Hand just above the knee. Sir, bring the knee into your face. Thank you. The hands are switched because now we will be evaluating hip extension. Patient is asked, sir, can you push me away? Push, 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 push. No. We need you to push this time. Yeah. All right. So the patient is asked, sir, can you push? And usually the examiner is easily overcome by this motor movement. Again, the contralateral leg is bent the hands are switched and the muscle is palpated. Sir, can you push me away? Push, push, push. Perfect. Okay. Then we will evaluate for flexion at the knee. The instruction to the patient, can you bring your heel towards your bottom and the ankle is held and the knee is supported. Can you bring your heel in towards your bottom? Very good. Can you bring your heel, towards your bottom? Perfect. Then, knee extension, subserved by the quadriceps, L3, L4, L2, 3, 4. Patient is asked, can you push me away? Push, 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 in an attempt to straighten the leg or to extend at the knee. Can you push me away? Push, push, push. And again, the patient extends the knee. Now, the actions around the ankle, dorsiflexion, which involves asking the patient, sir, can you bring your toes towards your face? The ankle joint is brought to about a 90 degree, and the patient is asked, keep your toes towards your face. And the examiner's hand is placed on the dorsum of the foot and resistance is applied. And the patient again is able to maintain that posture. Likewise, on the contralateral foot, the ankle is placed at about 90 degrees and the patient is asked to maintain this posture. Then we ask the patient to plantar flex, and we have a local phrase to ask. Sir, can you push your foot into my hand? Push, 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 push. And we are unable to change the angle of the ankle joint. Can you push, 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 push? Perfect. Then finally, the toes. Sir, can you bring your toes towards your face? For extension of the toes, S1 myotome, and we evaluate the great toe and we ask the patient to maintain that posture. Sir? Perfect. Reflexes of the patient. Biceps. The arm is flexed at about 120 degrees. The tendon is stretched with the outstretched index finger, and the patellohammer is struck perpendicular to the direction of the bicep tendon. Please note that the patellohammer is held just at the tip and it is allowed to fall in an arc. That is the normal bicep tendon reflex. C5, C6. Again, tendon is stretched, patellohammer is struck perpendicular to the tendon. The patellohammer falls in an arc. C5, C6. Again, it is our responsibility to decide whether or not the tendon responses are diminished, meaning 1+, they are normal, 2+, they are increased or hyperreflexic, 3+, or whether there is the associated pathological finding in the upper limb of Hoffman's or in the lower limbs of clonus. And the presence of those two will give the patient a grade of 4+. For the triceps, the arm is held at about 90 degree flexion, the elbow is supported, the tricep tendon is palpated, and again, the patella hammer is struck at 90 degrees to the tendon. The patient extends at the elbow. Again, for the supinator, the landmark is the radial stylus, and just proximal to the radial stylus, oftentimes we put our hands over that area, or it can be struck directly. Perfect. The final maneuver in the upper extremity is to evaluate for the presence of Hoffman's. The patient's middle finger is held usually at the level of the proximal interphalangeal joint, and the distal aspects of the finger is flicked downward. And with Hoffman's, what we see is flexion of the associated fingers in response to this maneuver. Of note, this is not present. Patient has to be relaxed. Hoffman's is absent. This patient had normal or 2+ reflexes in all myotomes. In the lower extremity, the knee jerk, again L2, 3, 4. The knee is held at about 120 degrees. The patella is palpated, and the tendon is just distal to the patella. Now, I am left-handed, and so I strike the patella tendon overhead like this. However, for right-handed students, this is the posture. Again, the tendon is palpated, and it's struck perpendicular to the tendon. And this is repeated. The tendon is palpated, and the reflex hammer is applied perpendicular to the tendon. For the ankle response, the limb is placed on the contralateral limb. The ankle is flexed, allowing for stretch in the Achilles tendon. The knee is about 90 degrees. And again, the Achilles tendon is struck. Relax, relax, relax. Now, sometimes, if on the initial attempt a response is not seen, then you may invite the patient to do what is called the Gendrasic maneuver, which is, sir, can you interlock your fingers like this and pull when I say pull? After 2, 1, 2, pull. And it's struck at the same time that the patient pulls, and oftentimes, if they have normal responses, the jerk will be seen. Thank you. Thank you. Let's bend at the knee. Bend at your knee. Again, applying Marcel. I'll tell you when to pull. After 2, 1, 2, pull. All right. In this case, the ankle jerks are bilaterally absent. Two final maneuvers. Number one, evaluating for clonus. Relax. And that is applied by flexing at the knee and having the ankle held in its anatomical position. The whole point is to suddenly and rapidly flex or stretch the Achilles tendon. Again, for patients with clonus, what is seen is repetitive beats around the ankle joint. And what is required is 5 or more such beats in order for it to be sustained and therefore pathological. Hoffmann's and clonus are features associated with the pathological involvement of the corticospinal tract. In other words, further evidence of an upper motor neuron lesion. We will now demonstrate the Babinski response or the plantar response. The hand is placed below the ipsilateral knee, and a blunt object, classically a key, is run along the lateral aspect of the patient's foot and onto the ball of the foot. Again, lateral border of the foot, and what you see is outward fanning of the toes and extension of the toes, as well as flexion of the ankle, flexion of the knee, and extension of the contralateral foot. And that constitutes a positive Babinski response, which is pathological. Let's do the other. Again, the outer aspect of the foot and onto the ball of the foot. And what is seen, again, extension of the great toe, fanning of the rest of the toe, flexion of the ankle, flexion at the knee and hip, and extension of the contralateral foot. Having done that, the point of doing the motor exam is to detect various patterns of weakness. We can see a paraparesis, which involves weakness of both limbs, both lower extremities. We can see a hemiparesis, involvement of ipsilateral arm and leg. And we can see a quadriparesis, involvement of all 4 limbs. There are different patterns, whether distal weakness versus proximal weakness. And in your lectures, we will zone in on the various causes of these. Likewise, with the distinction between upper motor neuron and lower motor neuron processes, again, upper motor neuron processes characterized by preserved bulk, hyperreflexia, hypertonia, with the presence of Hoffmann's or clonus, with positive Babinski response as discussed previously. Lower motor neuron processes include wasting of the muscles or loss of bulk with fasciculations and hyporeflexia. Now, we hope you had fun learning the motor exam. Please practice and practice well. Thank you very much. Students, we're now going to be looking at various abnormalities related to your gait. We will begin with normal gait. Normal, so we will ask the patient, Marcel, can you just walk normally down to that chair? No, just walk normally. So in evaluating the gait, we look at the stride length, which is the distance between the patient's steps. And usually they're on average about shoulder width apart in length. We also look at the base of the patient. Most patients have a narrow base wherein the longitudinal axis of their feet do not stray outside of the width of their shoulders. Perfect. Also, as it relates to the gait, the patient's arms move fluidly at their side. So turn and walk. So we will note that this patient has a normal stride length. Their stance is narrow, and the arms move fluidly at their side. Perfect. In some patients, for example, who have cerebellar disease, what is known is that their stance becomes very wide. And so the patient assumes a wide-based gait. Marcel, just spread your legs apart just a little more than shoulder width apart. Keep going. Keep going. Right. And the patient, when they walk, they maintain that wide base stance. So can you turn around, keep your legs apart as you walk, far apart. Further than that, Marcel. Right. And oftentimes with cerebellar disease, the person sways or staggers from one side to the next, and oftentimes falls preferentially to one side. And that is the hallmark of cerebellar disease, a wide-based gait, ataxic gait, oftentimes falling to one side. The other gait is called, Marcel? So this is the one where I need you to lift the toe last off the ground when you're walking, okay? The other gait is what's seen in patients who have a peripheral neuropathy with a foot drop, for example, a unilateral foot drop, where the patient has a high stepping gait where the toes are almost dragged along the floor. Marcel. The toes are the last parts of the feet to be lifted above the ground. And this is seen in a patient who has a peripheral neuropathy. And that is called a high steppage gait. Now finally, or no, not finally. Another example as it relates to gait is what is seen in patients with an upper motor neuron lesion, for example, a stroke. What is seen is adduction of the involved limb with flexion at the elbow, flexion at the wrist, and flexion of the fingers. That is the posture of the upper extremity. However, in the lower extremity, the patient has extension at the hip, at the knee, and at the ankle, and circumlocution of the leg. Right. And so in patients with upper motor neuron pathology, on ambulation, there is circumlocution of the lower extremity. And the hand is kept close to the body, elbow flexed, wrist flexed, as well as the fingers. Perfect. Okay. Final example is in patients with extrapyramidal involvement, for example, various Parkinsonian syndromes like Parkinson's disease. Usually what is seen is the patient has a stooped posture, that the base of their stance is very narrow, and they take short, festinating steps. Of note, they have reduced arm swing, and when they turn en bloc, and we will demonstrate this now. Marcel, Can you just turn? Turning en bloc and then walk quickly in rapid, short, festinating steps. Note there is decreased arm swing. Can you turn for me, Marcel? Notice the patient turns in minute segments in a 360 degree, and that is called turning en bloc. Usually, when someone is walking normally, they turn quite fluidly, usually beginning with their upper trunk, with their trunks, sorry, like this. That's how we walk normally. Okay. The last maneuver is doing what's called tandem walk, where the patient is asked to toe a line and to put one foot directly in front of the other. Usually this is a function of both dorsal column health as well as cerebellar health. And so in patients who have dorsal column disease, what is noted is that they have an inability to perform this task. If the patient has unilateral cerebellar hemisphere disease, what will be seen is that the patient will fall preferentially to the side of the cerebellar lesion. We will also end with what's called the Romberg's sign, and this is another test for dorsal column health, where the patient is asked to stand about just short of shoulder width apart, straight and tall. The arms are outstretched, usually with the palms facing up. And then the patient is instructed to close their eyes. Close your eyes. And a person with normal, healthy dorsal column function is able to maintain this posture indefinitely. For patients, however, who have dorsal column disease with impairment in proprioception and joint position sense, what is seen is that the patient sways and sometimes falls backwards. And this is called a positive Romberg's sign. So thank you for participating in the performance of the gait and coordination. Please practice, as these tools are important. Thank you.